for those of you who've kind of wanted to key in a little bit earlier, we're going to spend a few minutes talking about right atrial pressure contours, which is the same as what you're going to see on your jugular venous pressure, which is the same as what you're going to see on your left atrial pressure, which is the same as what you're going to see in your hepatic veins by Doppler. But there's some characteristics, abnormalities that occur that you have to be aware of. So we're going to start here and just kind of draw out for you a normal, let's say, right atrial pressure. And here's your A wave there, which is atrial contraction, remember. Here's your X descent, which is atrial relaxation and descent of the annulus toward the base, because that's ventricular systole. Then your V wave is there, where the blood starts coming from the vena cava or from the pulmonary veins, filling the right atrium or the left atrium, so there's a rise in pressure. And then at this point in time, mitral valve opens, and you've got a fall in pressure, which is the Y descent. And that's your normal right atrial pressure, which is about 5 to 8 millimeters of mercury. Now, there's abnormalities that occur. Let's say one of the first abnormalities that you think of is a person with something like this. So that's a large A wave. And that's seen in either pulmonary hypertension, pulmonary stenosis, any type of right ventricular hypertrophy in which you have a stiff right ventricle. It can also be seen in a patient with tricuspid stenosis, but in tricuspid stenosis, their Y descent will be blunted. But remember, a big A wave, if you see it, followed by systole, is a stiff right ventricle from either pulmonary hypertension, pulmonary stenosis, or right ventricular hypertrophy. Then what you can get is this, of course, which we'll be talking about Tuesday in valvular heart disease, but a big CV wave. And actually on the right side, your V wave looks different than it does from the left side. Now, if you're on the left side and you have severe mitral regurgitation, you're going to get a V wave that looks like this. In tricuspid regurgitation, which causes a large CV wave, the wave is more holosystolic. And you see that on your Doppler, you see that on your physical examination, so on and so forth. Then there's this group of pressures in which, let's say the first one is an A, rapid X descent, V, rapid Y descent. And this is something that Steve Ammon's going to go over. A, V, rapid X, and a rapid Y, which of course is constrictive pericarditis. And that's because your atrial contraction's still intact. That's because you still have good descent of the annulus during ventricular systole from the base to the apex. That means at the time of tricuspid valve opening, there's very rapid filling into your right ventricle, and then an upstroke in your pressure, which causes a rapid X descent and a rapid Y descent. Then you've got patients who have a blunted X descent, and a rapid Y descent. This is the group of patients that Steve talked about the first part of the course, which is myocardial restrictive disease. Patient maybe with amyloidosis, patient with idiopathic restrictive cardiomyopathy, but basically your X descent is very blunted there because your atrium's probably not contracting well, and probably the annulus descent is very poor. So it correlates with a low, let's say, E prime on your DTI and a low systolic wave on your DTI, which means the annulus descent is doing well. So the difference between myocardial restrictive disease and constrictive pericarditis is the loss of the rapid X descent in myocardial restrictive disease. And then finally, you might have something where you have a very, very good Y descent and a very, very good X descent, but your Y descent is blunted. And that is cardiac tamponade. Because in that case, at the time of tricuspid valve opening, the pericardial effusion is just compressing the heart so much that blood can't come in from right atrium to right ventricle. And actually, it's that atrial contraction and atrial relaxation that's driving, that's kind of compensating for things, keeping the blood going. And if this patient would go into atrial fibrillation, they'd have a real disaster. So what I've pointed out is the normal right atrial pressure contour, or normal jugular venous pressure at the upper left. And then we see some of these abnormalities that you have to recognize: big A wave, right ventricular problems, big CV wave, tricuspid regurgitation, rapid X and Y descent, constrictive pericarditis, rapid Y descent, myocardial restrictive disease, rapid X descent with a loss of Y descent is cardiac tamponade. I mean, it's something that you should be able to figure out just based on the pathophysiology and the physiology of how the atrial pressures change, but something that's going to be quite useful for you, not only in taking the boards. There'll probably be 1 or 2 questions on this, but when you're in the cath lab or when you're in the exam room seeing patients.